Good afternoon. Welcome. Our next speakers are Kristina and Kate Sheridan, mother and daughter. And I was going to say how patient involvement is their passion and their job, by the way. But then I was talking to you, Kristina, last night, and then I suddenly became aware of the fact of the meaning of what you're doing when you told me that it always takes your breath away when you're here with your daughter on this stage. And I would like to welcome both of you to tell your remarkable story to this audience. Thank you very much.
Thank you so much, and thank you for including patients and caregivers in this conference. We are absolutely delighted to be here to share our stories today. As many of you in the room, I didn't start my career in healthcare. My background is astronautics and space engineering, so I spent my first 20 years launching, operating, and sometimes rescuing communication satellites. But in the fall of 2006, 2 of my 4 children came down with flu symptoms, and our lives completely changed. But before I describe my patient experience and the research that our family story inspired, I'm really proud to introduce my daughter, Kate, who's going to share her patient story.
Thanks, Mom. Over a decade ago, when I was in 5th grade, I suddenly developed flu symptoms and a classic bullseye rash on my face. I was quickly diagnosed with Lyme disease and given 3 weeks of oral antibiotics. Despite what we thought would be a relatively simple diagnosis and treatment, my health continued to decline. And over the next 3 years, I was referred to over 30 doctors, given 15 different diagnoses, and was hospitalized 5 times. During that period, all the parts of my life that I had taken for granted began to change. I went from being a straight-A student in an advanced academic program to a special needs student unable to read a single page of a book. I was diagnosed with a heart condition called dysautonomia and went from being a competitive athlete to bedridden. And my pain levels became excruciating, running between a 7 and a 9 out of 10 all the time for 18 months straight. I was just turning 14. These symptoms robbed me of my ability to read, to run, and to write, but I loved art and was able to continue creating pieces through much of my illness. Art was a coping skill that helped me to communicate a lot of what I was experiencing, and so several of the slides that I'll share with you today will include pieces that I created during that time. So over those first 3 years, we built a team of 6 specialists, top in their field, who were dedicated to improving my health. But despite their help, I continued to get worse. I was spiraling downwards. And my family and I were overwhelmed with everything. Appointments became a blur. I had received so many different diagnoses and treatments that trying to accurately communicate my medical history had become impossible. When my physicians referred us to yet another consultation, my parents spent weeks collecting and organizing my medical data in an effort to tell my story more effectively. We talked together about how we were going to use that data and approach the doctors this time. We wrote down all of our questions and comments, and we made a plan. And that was the turning point in my care. By utilizing my data, building advocacy skills, and finding a holistic approach to my treatment, we were able to build stronger relationships with my doctors and improve the way that we cared for me at home. So when I first got sick, my life very suddenly fell out of my control, and I was inundated with terms I didn't understand, invasive examination, and isolation from my peers. Many of the conversations that directly impacted my care happened around me, and I could go through a lot of appointments where screen time replaced personal eye contact and recognition. It felt like I walked into the appointment as a person, and I sat down as a diagnosis. And because of this, figuring out how to communicate with my doctors was a vital component in improving my care. Advocacy was a learned skill set. It was like picking up an entire new language. There was medical lingo we needed to memorize and cultural norms that we had to navigate. And we had to advocate outside of the doctor's office as well. There are a ton of things that chronic patients have to deal with on a day-to-day basis, both related to and beyond treatment. And Viet Thai Tran and colleagues call this the taxonomy of burden, and this is a term that ePatient Dave has also highlighted. And it's this idea that it's not just healthcare tasks that patients deal with, right? It's the consequences of those tasks and all of the other factors that worsen the burden of treatment. So for example, my first day of school as a 16-year-old was spent trying to stylishly hide a heart monitor, look super cool, and literally try not to have a heart attack. Balancing all of this stuff was impossible to do with just traditional medicine. And by the way, the consequences of all of these were not really well addressed by any of the tools that we had access to. We had to find out some kind of way to both treat my illness and improve my quality of life. And so in addition to my treatments, I built up coping skills, taking things that were a part of my identity and repurposing them into support systems. So when I could no longer play sports, I went from coach to athlete. When I could no longer hold due to color pencils due to arthritis, I switched to mixed media materials, which were a little easier to grasp. And when I could no longer sit at a piano for long times, I switched to the ukulele, which I could play sitting and in bed. And this helped maintain my identity. You know, despite everything that was going on, I was still involved in sports, I was still an artist, and I was still a musician. And those things were real priorities to me. As a teenager who had already lost a lot, they were crucial to getting through the day and eventually to my recovery. And we saw direct benefits to my care plan when we included them, right? When I could play music, I could deal with my pain more easily, and so I took fewer pain meds, and so I went to school more often, and so I was happier, and the whole cycle sort of continued. And my doctors really understood that. They heard me, and they took my feedback into account. We were included as equal partners in my care. So we'd figured out the language of advocacy, and we built up these coping skills, but we still had to figure out a way to take all of that information, plus all my medical information, and turn it into usable data that we could harness to really manage my condition. I was dealing with a lot of mental and physical symptoms, not to mention all the side effects, and that could be really hard to communicate, even to really engage doctors and to my parents. During one particular appointment with my cardiologist, who was treating me for a tongue twister of a condition called postural orthostatic tachycardia syndrome, he mentioned that he was surprised that I didn't have any numbness or tingling in my feet, given the diagnosis he wanted to give me. And I was laying on the examination table, and I responded that I had numb feet. My feet had been numb for weeks, but it just didn't seem important enough to mention. I mean, I was only in that appointment for 45 minutes. I was in constant pain, and I felt like I was going to pass out every time I stood up. I really wasn't thinking about my numb feet. And so that night when we got home, my parents sat me down, and we made a full list of every single one of my symptoms, head to toe. And we figured out that there were 26 of them. And we were pretty shocked, because I'd never mentioned more than 10 in a single appointment to any of my individual specialists. And so we set up a really basic tracking system in Excel, pretty similar to ones you might have seen on Wednesday if you came to the patient track. And we started writing down, well, I started writing down the severity of my symptoms every week or two and before appointments, as well as what kind of medications we were trying and the interventions that we were working on. And we shared that information with my doctors, pointing out any major changes to my condition since my last visit. But in addition to that quantitative data, we also began collecting qualitative data within that big spreadsheet that was just as important. Journal entries, questions and comments, taking pictures. All of these things helped provide a full image of what I was going through to my providers. And they told them more than just my test results could. They showed them how their care plan was affecting my ability to socialize and go to school, my mental health, and my quality of life. And that was kind of the final component in creating this sort of comprehensive data management system that really tied together my treatment schedule with the rest of my life. So we were now able to walk into appointments with 3 big new things, right? The ability to advocate for ourselves, the ability to better balance my life, and the ability to track an organized set of data. And for the first time, we were interacting with the US healthcare system, not as consumers of care, but as experts in what I was experiencing. We knew my day-to-day better than anyone else, and we now had the data to show it. So there are 3 overall lessons that we learned from my condition. First is that including my voice was central to my recovery. Interacting and recording my data put me more in touch with my body. It made it easier to communicate what was going on to my doctors, and it gave my care team an idea of the feasibility of the plans that they made. Second of all is that I only got better because we were given a seat at the table. And I really want to thank DevDays today for allowing us a seat at their table, and I want to thank you for listening to us and for including us in that conversation. But we need you to continue thinking about how you can include patients in your work every day. Health data has definitely revolutionized a lot of the healthcare industry, but many of the tools that are available today are aimed more at providers and clinicians than they are at patients. And then third, we need to continue building trust that my data is being used securely. When I was at my sickest, I didn't think a lot about the privacy of my data because I was desperate to get better. I probably would have traded privacy for recovery. And we're relying on industry when patients are in those vulnerable positions not to take advantage of our data and to make sure it's still being used for the right reasons. If you're profiting a bunch off of my information, I should also be seeing a lot of that benefit. So we talk a lot about the future of big data in healthcare, and it can be easy to get a little numb to the buzzwords, but data is also powerful, right? It's personal, it's powerful, and it tells a story. Behind me, you can see a small snippet of data. This is a compilation of spreadsheets and record entries and PDFs hand-typed at 2 a.m. And the sharp peaks are more than just changes in my numbers. They're dealing with intense bouts of pain. They're frantic trips to the emergency room, and they're being told at my lowest that there was nothing we could do but watch my symptoms worsen. And on the flip side, that plateau and decrease, that's moving my fingers for the first time without pain. It's putting my wheelchair into storage. It's breathlessly running down the beach with my best friends. These lines begin at me thinking I would never be able to live independently, and they end with me applying to college. And I can't tell you how powerful it is to be able to hold that journey in my hands. Being a chronic patient can feel like you're dealing with a million things, all by yourself with the highest of stakes. Our system allowed us to organize some of that chaos, and the space that it left us allowed us to make tangible steps towards my recovery. But we were really, really lucky. We had insurance, we had technology, we had amazing family and friends. I had a literal rocket scientist on my side. Most people don't. But we had the talent and we had the resources in this room to really change that. Thank you.
Thank you, Kate. It's always a little hard to go after Kate, I have to say. So Kate mentioned a turning point in her care. It was 3 years into her illness, and we had watched her go from a carefree 11-year-old to a 14-year-old debilitated by pain, desperate to get back into school, and really trying to hold on to her identity. My husband and I, at that point, were completely overwhelmed. Not only was Kate sick, but my son, who had also gotten infected 3 years earlier, had started to decline as well. We got so overwhelmed with everything we had to do that we just couldn't communicate the full story to their providers, and we were no longer able to advocate on their behalf. So we knew that we had to do something differently. So we took a step back, and as Kate mentioned, we gathered all the data from the 30 providers that she'd seen, and we hand-typed from those PDF files into Excel spreadsheets, just as you heard other patients do on Wednesday, to get the information to Excel spreadsheets. We also captured that other data that Kate talked about, that qualitative data, the symptom severity levels, and we compiled it into one cohesive story. We took one 11 by 17 sheet of paper, and across the bottom, we mapped out all the treatment trials that had occurred over those last 3 years. And then across the middle, we put her symptom severity levels so you could start to see the cause and effect of those treatment trials. And across the top, we laid the abnormal lab results that had prevented her providers from following through on those treatments because it made her too sick. And that was the data that we walked into the next appointment with and laid out, and were able to quickly articulate her entire story from start to end, and using our data in combination with their expertise in data, the doctors were finally able to unravel that she still had active Lyme disease infection, that she had developed an autoimmune condition that was causing her extreme pain, and that she had developed this form of dysautonomia that Brenda actually mentioned on Wednesday during the patient track. There were 3 complicated symptoms, all of which had overlapping symptoms. And so we, at that point, since they were finally able to unravel it, they came up with a treatment plan. And within 18 months, she could start to read again. She was back in school part-time, and she was coaching a little sister in soccer. 2 weeks ago, we had the pleasure of going to a graduation where she graduated from Oxford University with distinction. So it was a huge, huge thing for us. Thank you. I do want to pause for a second and thank every one of you in this room for what you're doing. Kate mentioned before, the window that we typed all that PDF data into those Excel spreadsheets was between midnight and 2 a.m. every night over a 6-week period. Hand typing everything. The work that every one of you are doing in this room right now is going to mean that in the future, patients can do that exact same thing very quickly through a touch of a button. And it's not only important because it relieves the burden and it takes the burden off those patients and caregivers, but it also reduces disparities. Because patients who don't have the background we were lucky enough to have are still able to do the same thing that we'll be doing. And that's because of everything that you guys are doing in this room today. So we do want to thank you very much for that. So there were two big takeaways from our journey that we had. The first one that was, even though Kate was only 11 years old and our son was only 8, they were experts in what was happening to them. They were the only ones who could tell us how severe their symptoms were, how the medications impacted them, and how it affected them at school. The other kind of aha moment I had was I was in the Launch Control Center and I was executing a launch mission, and I realized that it was easier for me to launch that satellite that day than it was to take care of my children's health at home. And the reason was that I had the tools in that control center to do what I needed to do. When I went home, I had no tools to help me apply the expertise that we had in order to help her recovery. That's what made me shift careers. I joined MITRE. It's a not-for-profit organization who focuses on complex problems and solving them. They have an independent research program, and I submitted a research proposal that said, how do we empower all complex chronic patients to have a voice, capture that voice as hard data, so it can improve their outcomes and help them self-manage. So we started a research program, and the first thing we did is we stepped back and we said, what is it that every complex chronic patient needs at a minimum in order to help them do that? There were 3 areas. One, they needed help self-managing at home in the 99% of the time that they're outside of the clinical setting. The second one was the desire to have better communications with their providers. And the third one was tools that were really designed for them, that were easy to use and did not add burden but helped. So then we moved forward and we did some foundational research. The first thing we did is we collaborated with Carnegie Mellon and we did a provider survey. And we asked the providers, what is the patient data that's going to be important for you for clinical decision making? And they told us that longitudinal symptom severity data and longitudinal medication compliance data would really support them in diagnosis and treatment evaluation, but they had no access to it and they were concerned about the accuracy of it if it was collected remotely. So then we connected up with University of Virginia and we did a clinical study with multiple sclerosis patients. And we had multiple sclerosis patients track their symptom severity levels at home over a 6-month period and also track it in the office. And we were able to prove through that study that the data collected remotely through a tool is as reliable as if the patient's sitting in the office with the provider and talking to them. In addition, the patients who were tracking their symptoms had an improved state of awareness of their disease state. So now we knew the data was needed by both providers and patients, and it could be reliably collected, so we moved on to build a tool. But before building technology, we wanted to make sure that whatever we built was something that a patient would want to pick up every day and use every day because it was beneficial to them and didn't add burden. So we developed patient workflows and detailed workflows looking at the decisions that complex chronic patients have to make on an everyday basis, and also looked at the workflow and how that interacted with the clinician's workflow. So we could identify the features to put into the tool that would alleviate the burden of those actions and times. And this research led to the patient toolkit. So it's a pretty simple application. The patient toolkit, there's a schedule on one side, so patients can have their medication reminders or appointment reminders. They can also put everyday life in there, because just because you're a patient, life doesn't stop. So it was important to give them a tool that fitted into their day as a whole. Within the tool, there's 4 sets of data that we collect primarily. The first set is the how are you feeling today data. And the reason we collect that data separately is because our clinical study with UVA showed that that single question very closely matches to the level of fatigue, pain, and depression in a patient. But it's also the one question that shows if a patient has external stress that's ongoing that's affecting them, that's the question where that information will show up. The other thing we do is we track symptom data. We have a symptom picker to help the patient identify a full set of symptoms across all of their diagnoses. So it's a holistic patient view of their symptoms. Once they've done that, they have a personalized tracker where they can track the symptom levels, severity levels from 0 through 10 over time when they're at home. The important thing we found as we did an environmental scan of existing apps is a lot of apps don't include data standards. So we built in the appropriate data standards to the tool, so those symptoms do map to SNOMED CT. So when you enable this data to be shared out to providers and the EHR systems step up and start including this data as hard data that clinicians can then use, the data is already in a format that will be able to be integrated. We also applied the appropriate standards to collecting of medication data, so we use RxNorm. And for the medication, the patient has all of their medications within the tools. They get reminders to take their medication. But the critical part is, with the reminder allows the patient to say, I'm going to skip it. Because patients have really important reasons for skipping medications sometimes. We focus so much on compliance that we forget that there's a good reason for not taking it. And understanding that reason now allows you to change the treatment plan to be something that they can follow. So the app gives the reminder. If they skipped it, they're prompted on reasons. There's 5 standard reasons they can also customize. So now the provider has a real understanding of what's occurring. And the last set of data that we collect, Research has shown that when patients journal, they tend to have better outcomes. So we have a journal feature built in. The other advantage of that feature is that when you're a complex chronic patient, often your appointments are 1 or 2 months apart. And so you forget those critical things you want to raise with the provider. So there's a journal note in there. You can take photographs, do audios, do text, and you can tag that note for the provider so that you remember to tell them. So those 4 elements of data pulled together represent that patient voice, that right now when patients walk into an appointment, they have to do everything from memory under a very stressful situation. Now they have accurate data caught at the time in order to walk in, and the tool helps them organize that information when they go to their appointment so they can step their way through it. But ensuring that the patients use the tool, you have to provide them value at the time that they're using it. So it was very important from a visualization standpoint to represent the data back to the patient so that they could use it for daily decisions, in addition for the providers to be able to use it to make their decisions. So we developed a graphical view. The graph has got across the top individual symptom severity levels. The second bar down I'm going to come back to. The one below that is the how are you feeling today data. Below that, you can see the medications, when they started, when they stopped, and if they took them. So you can start to see that cause and effect. When I started that medication, did my symptoms improve or not? And it's very important, again, when you're designing the tool, to give value to the patient. So when Kate was sick, the only way I knew something was getting worse was my gut would knot up. But I couldn't, she was so complicated, there was so much going on, I didn't know why. So the second bar, the gray bars that you see there, every day that a patient tracks their symptom severity level, we total the severity across all of their symptoms, so it's the total burden of illness on that patient. And so when your gut knots up, now you can look at that and see whether it's actually increasing or not. It validates that gut feeling that you're having. You can drill down on the bar and see which of those symptoms are actually driving it, and now you're actually empowered to pick up the phone and talk to your doctor and tell them what's going on articulately, and potentially avoid a crisis or a trip to the ER. So having those sort of features make it beneficial to the patient on a daily basis, but also to the provider. And we also have a dashboard view that, again, you can drill down into. So we completed the tour, and we got great feedback, and we took a step back, and I kept looking at it, and I'm like, this is a pretty simple tool, right? This is not rocket science. I know it's not rocket science. It is not, right? So I'm looking around, and I'm thinking, why is this not everywhere? Why are these features not built into everything we do to support patients? And so our research took a slightly different track, and we said, okay, what are the barriers to adoption of patient-facing tools today? And we identified several. I don't have time to talk to every single one of them, but what we ended up doing on our research is we identified the barriers to adoption first through literature review. Then we researched for each of them what was the best practice to mitigate that barrier. And we went through and we systematically mitigated those barriers. And we collaborated with the Billings Institute out in Montana to execute a formative evaluation to see how successful those mitigations would be. I do want to touch on a couple of these that I think are most pertinent to the team here. The first one is the complexity of use. We initially did significant testing within MITRE, right, of the application itself. Usability testing, we kind of pounded on it. Great. And many people I've spoken to here do a significant amount of their testing within their organizations. But we realized as we researched that that's a core issue, right? Everyone at MITRE is tech savvy. And so we weren't truly getting usability testing for those patients who we were really trying to reach. And not only that, if we were only testing internal to our organization, we were actually making health disparities worse, because those who were used to technology would have the tool and those who would suffer. And so what we did is, again, we collaborated with a rural hospital out in Montana, the Pioneer Medical Center. We had patients come in who were not tech savvy, were not used to using technology. We had them use it, do formal testing, and then redid the design to ensure that those patients could equally use it. The other piece that went along with the complexity of use on the research was the appropriate training for patients also. So we really went through to understand what level of training was required in order for that to occur. The only other one I'm going to hit on, and I'm happy to talk, I know we're limited on time, so I'm happy to talk about this other ones later, but it's for sustainability, one of the critical pieces with the integration into the electronic health record system for the provider's use. And I cannot emphasize enough our hope that the EHR systems will start to recognize this patient data as really important information and integrate it as hard data rather than just PDF files. So we moved forward, we did our formative evaluation study. The results kind of speak for themselves. Industry standard retention use after 1 month is 42%, and at the end of our 1 month formative evaluation study, we had 86% retention. The patients, importantly, found the tool very easy to use, as did the providers. There was, and this was critical, there was a perception of usefulness. So both the patients and the providers found the tool very helpful and useful. In particular, symptom severity tracking, life notes, and medication compliance levels. And both patients and providers agreed on the particular features that were most valuable to them. The other big barrier that we were able to overcome, or at least address and measure, was a concern by the providers that the workflow will be impacted. And what we were able to show in the formative evaluation study is that even though the intake time for the patients was a little longer, the actual room turnaround time was the same. So there was no impact on the actual execution of patient care within the clinic, which was very important for the provider's point of view. And equally on that side, when the patients walked in, they were more prepared to have that conversation. So at a high level, we kind of pride ourselves when we talk about patient-centered care. We put patients and caregivers in the middle. What we are pushing for is to go beyond that and take the next step, which is recognizing patients as experts and really recognizing them as partners with their care team, because we believe that that's going to take us a step forward from where we are today. So we are incredibly lucky. We had the resources and the support to be able to capture Kate's voice as hard data and make sure that her providers could leverage that to get the outcome that we could. But there are hundreds of millions of complex chronic patients, and many, many out there who don't have that ability today. So our ask of you today is to really recognize and treat patients as experts and prioritize as experts the capture of their data and the exchange of their data equally to the capture and exchange of other clinical data. Because once we're able to do that, we as a community will empower all patients to be able to have the type of outcomes that we were lucky enough to have. Thank you so much.
Well, thank you very much, Kristina and Kate. I think we do have time for one final question before we dive into the tech again. Who has this burning question? I bet Dave has one. Okay. Dave.
Since you asked, so what are you doing with this? Is this a product for people to buy or what? Or is it open source? What are you doing?
Sure. So right now, the tool is available. Yes, sorry. So the tool was, what are we doing with this thing, right? So MITRE is a research organization. We're a nonprofit organization. We don't commercialize it ourselves. We do actually license it out at a very low-cost license to other vendors so that they can take it out and integrate it. But we've recently stood up a foundation, actually, that will now allow us to collaborate with others in order to get the tool out there. So if anybody is interested in working with us, we would love to get this further out and adopted out by patients. And actually out into the real world much more significantly, because so far we've been using it for our research purposes and our clinical studies and licensing out to some small companies, but we would love more interaction if anybody's interested in doing that. Thank you for the question.
Thank you very much.
Thank you.
Thanks.
Okay.